At this time, I would like to introduce you to our speaker. Jill Lord is the senior leader responsible for community health at Mount Ascutney Hospital and Health Center. She has been a nurse for 40 years. Jill was appointed to Governor's Blue Ribbon Commission on Nursing in 2001 and 2011. In 1998, Jill was instrumental in creating the Vermont Nursing Internship Program and has served as president of the board since its inception. She served as Director of Patient Care Services and Chief Nursing Officer at Mount Ascutney Hospital and Health Center for 24 years. As a nurse leader, Ms. Lord has a strong community health influence through Mount Ascutney Hospital and Healthcare, leading the Windsor Area Community Partnership, the Blueprint for Health, the Windsor Area Drug Task Force, Mount Ascutney Prevention Partnership, Volunteers in Action, Chaplaincy Program, and the Patch Network, in addition to a myriad of other community health initiatives. Under Jill's leadership, Mount Ascutney was selected as a national finalist in the prestigious Foster McGaw Award for Community Health in 2002 and the winner of the award in 2012. Jill works to foster high-quality patient-centered care through administrative supervision and support for staff programs. Additionally, she leads the local area multi-facility ethics committee, the Windsor HSA Community Collaborative, and the Mount Ascutney Hospital Community Health Committee. Now I will turn it over to Jill.
Thank you, Kim, and you did a really nice job pronouncing Mount Ascutney. I appreciate that.
Thank you.
I appreciate also the opportunity to talk with everyone today and share our experience. My hope is that through this time together that I'll be able to give you some background to the extent of the issue of substance misuse and the opioid crisis in Vermont, and talk about some of our work and the best practices that we've used to address the program here. I'll share the information that we have about outcome measures so that we can track our effectiveness, and then certainly open to questions and concerns or any comments. I'm sure that in the audience today there are many people with equal amount of experience and expertise, so happy to hear from you in the process. Okay, so the little engine that could. I think all of us feel like, although when you work for a critical access hospital, we may be small, but we're mighty. We're nimble and able to implement best practices in a way that might be more difficult in a bigger institution or tertiary care and so on. I did go over the objectives as I did my introduction, so I won't repeat myself. But again, I'm hoping through this time together we'll be able to answer some of the questions you have and maybe relate some experiences that can help you in your battle in your communities. So a little bit about Mount Ascutney Hospital. We are a not-for-profit, rural critical access hospital. We've been in operation since 1933 and always been a community hospital with strong support from the community. There's a famous story about the hospital where we had to move from, small hospitals started in houses, and ours was no different. In the 1930s, it grew out of a stately home in the middle of town, and we recognized that we needed to modernize in the later years. And there's a famous story about the then director of nursing who was meeting with the state as for permission to build the hospital as the construction trucks were moving by the meeting room. In other words, the hospital actually raised all the money that it took to build the new facility from the community, which I think just tells you that partnership and network and strong community support are what community hospitals are all about. We're a member of the Dartmouth Health Alliance. Our hospital has been awarded the National Committee on Quality Assurance Level 3 standing for our patient-centered medical home. We are CARF accredited, or the Commission on Accreditation of Rehab Facilities. And as Kim said, we've been a winner of the Foster McGaw Award for Community Health. The extent of the problem, we, as you do, complete a comprehensive community health needs assessment every 3 years. This needs assessment is completed after extensive and in-depth community survey, doing numerous focus groups, and doing an analysis of our data, the performance data, morbidity, mortality, ED admissions, and things like the Youth Risk Behavior Survey, or BFSS surveys. We put that all together to determine our priority of needs to address. Those become our marching orders for the next 3 years. And the work we'll talk about today really came out of the marching orders for our #1 problem, which was identified as alcohol and drug misuse. And you can see that the usual and typical items probably for you are also on the list of access to mental health and affordable health insurance. But #1 and #2, clearly alcohol and drug misuse, and then heroin and misuse from pain medications. So here we go. I don't know that you can see that very well on the screen, so I'm going to interpret it. From the Community Health Needs Assessment and the different venues that we use to gather the data, this was, again, the top item. So one of the things we did, community and key leaders surveys in the process, and 39% of the community survey respondents identified that substance abuse recovery programs was an important area for us to focus on. Again, those are the marching orders. We had community discussion groups, and again, these discussion groups identified a high priority issue was the impact of substance abuse on the family functioning, its strength, and community safety. And then the third, with the health status indicators, it's significant that the rate of emergency department utilization for substance abuse-related mental health conditions was more than triple the rate for New Hampshire, and that our neonatal abstinence syndrome discharges was also triple the rate for New Hampshire. I wasn't able to get Vermont data, so I can't share that with you, but for a small community, this is just it's a problem, and I know you know nationwide, but we feel it at a significant and very personal level. It feels like it's an epidemic that we've been going through in a short period of time, and really needing to address in a coordinated and best practice way. So these aren't numbers that I'm bragging about or happy to talk about. What I'm happy to talk about is how we work together as a community to address the issue, and watching the numbers as we move forward. So, you know, we've adopted in our community health practice taking an approach that is built on partnerships and on best practices. I would say those are the two prime tenets of how we approach things. We know that we can't do things alone as a community hospital. And together, combined with the resources of our partners, we can go farther, faster and in a more coordinated way. We are a community that has adopted the approach of becoming an accountable community for health and addressing our issues at a population base level as well as for the individual. We serve as an integrator for all of the groups that you see listed on this chart. And I won't go into them in detail except to say that we have over the years, and I'd like to give credit to the Drug-Free Communities program through SAMHSA, because it was the lessons learned in that program that helped us form the infrastructure that allows us to do what we're doing today. And this was in the early 1990s, and through a 10-year course that we were able to build an infrastructure in addressing the issues of substance abuse. I think the other lessons we took from that experience are adopting a best practice approach. In other words, using the lessons learned and the research from national experts through the CDC and SAMHSA, and those that have experience, instead of, well, what feels good or what we think would work. We really need to go and see what has been working in other communities and adopt those practices. And so those are the two tenets, I guess, that I'd like to highlight for you. Each of the groups that you see listed on this list are multi-facility partners that also weave private citizens and groups into the process. It's a matter of having different vehicles and forums to be able to communicate, because you can't communicate enough. The sharing of resources and the sharing of information to help the community as a whole move forward. So this is our way to do that. I'll leave it at that. One of the mechanisms that we use is making sure that we maximize the resources we have. As you know, as a small community, we can't replicate what's available in larger communities with greater resources. So what we need to do is make sure that as many people that can be are aware of the resources that are available. So we worked with Dartmouth Hitchcock and have, over a period of about 10 years, created this Treatment Works consumer guide for substance use treatment. What you can find within this resource, which I'm happy to make available to folks, is all of the listings of the accessible programs for inpatient treatment, for programs through the state, for programs with private counselors. And what I need to tell you about Mount Ascutney is we're a border community. So we need to include resources for our communities that encompass both New Hampshire resources and Vermont resources. Even though we live in Vermont, a third of our population that we serve comes from New Hampshire. So what we've done is, on a systematic process, we've amassed those resources, and then we update those and keep we have both paper copies of this resource, and we have online so that people can access the resources in as timely way as is needed. I think you know, or probably in your communities, the same phenomenon is happening because of the extent of the problem of substance misuse and the opioid crisis. There's been a proliferation of resources to address it. So we need to keep on top of what's available to be able to make this as accessible to the people in need as possible. So this is one of the ways that we do that. The other thing is, you know, even having a resource such as the consumer guide available that's locally based, people get confused. Where do I go? Who do I talk to first? You know, I did a focus group with some folks in medication-assisted therapy, and I, you know, looked into their eyes and said, you know, for you, what's the biggest issue? What do we need to address? And you know, there was a loud outcry of when we're ready to make a change, we need help then. It's that timely access to care. So that's been a real concern for us as we've built our resources in the community. So one of the things we did was we worked with our deemed mental health agency. They developed access coordinators. And what we did with the consumer guide is, you know, we said on the consumer guide, and we worked and to communicate in the community, you know, if you're confused and you need one point of reference, call these people at this number. And I know you usually try to stay away from names and so on, but in this case we wanted to give people, you know, make it as comfortable as we could with folks, and so we gave them the numbers for both Springfield and Hartford, and their numbers. Now, the one of the underlying aspects of making this possible is having a relationship with that agency and the cooperation of the agency to have them be comfortable for us to have like a one-stop shopping. And our Dean Mental Health Agency has been great in this respect. They've been an amazing partner. One of the best practices and one of the things that I'd like to highlight today is our Hub and Spoke program. I don't know if you've heard about that program. I would like to really credit Beth Tansman, who is the current leader of the Blueprint for Health, as the driver of this program, who really made the case to Medicaid, saying, you know, we need to invest in treatment and care coordination for our folks that are suffering and going through the struggles and challenges of substance misuse. If we're going to have a dent in the program, this is an upfront investment, which will, we can show you, save money and reduce costs over time. And they have not only made the case with our state legislature, and were able to make the changes so that this program was offered through Medicaid, but they concurrently put in to place measures so that they could track the outcome and the impact. So what happens with this program is that for every 100 patients who are receiving medication-assisted therapy in the form of Suboxone or Vivitrol, we are given a full-time nurse and a full-time licensed counselor to work with these patients. And we've used the standards that have been developed from the health home measures that you see listed on the slide. So they're involved in the comprehensive care management to really address the social determinants of health. We know that's important. People are experiencing homelessness. Finances are regularly a problem. You know, are they maximizing use of the resources and the social service agencies that are our partners to really address the issues of life that they're going through, as well as the need for counseling? That comprehensive care management is an important tenet of what's happening through in a real systematic way throughout the state of Vermont. So comprehensive care management, counseling, care coordination. There's the actual opportunity to talk about health promotion and provide health education. You know, one of the issues that's so relevant to patients who are experiencing substance misuse is dental care. And in Vermont, dental care is, again, it's a scarcity. You'll find that because of lack of providers is on our hit list also for our community health needs assessment. So being able to work with our nurses in the SPOKE program and being able to access help finding a dental home is just an example of what this program can do. Comprehensive transitional care for both the individual and family support. What that means is we really pay attention to those transitions of care. Admission to the hospital, admission from the hospital, admission to the ER and from the ER, admission to an inpatient facility. So those are high-risk times that we want to make sure that we can link our patients to resources and have a smooth transition in the continuum of care. And this program allows us to do this. And then, obviously, building partnerships in the referral network of our community and social human service support services. It's an amazing opportunity for us, which we have found has made an incredible difference both in the lives of the individuals that we serve, but also statewide in the population health of and addressing the intensive nature of this disease process and its effect on both the individual and their family. We in Mount Escutney, we're a SPOKE program. The hospital is the administrative entity responsible for the program. We hire the staff, and they work with our individual prescribers in the patient-centered medical home who prescribe, and also specialty practices. We have Connecticut Valley Recovery Services that we provide SPOKE services to, and the Bradford Psychiatric Associates. So they're based in specialty practices. Again, we have found that their partnership and work with these specialty practices has been nothing less than transformative. It's really helped provide the needed services for group counseling, individual counseling, and case and care management and health education that these practices were not able to provide before. I haven't spoken about the hub, but the companion of the SPOKE program is the hub. And so there are hubs throughout the state. I believe there are 5 or 6 hubs. Our hub actually is located in New Hampshire and serves New Hampshire and Vermont patients. And these hubs are the methadone clinics. These are for that higher level of intensity of care where people need daily dosing. So we have a relationship with the hub, hence the hub and the spoke, in the wheel that moves us forward. The hub, we will send patients that we serve in the spokes when they show signs of really needing more intensive care to the hub. And likewise, the hub will send patients who become stable and don't need daily dosing to the spoke. So it's a very collaborative process we find that patients move geographically. There's a lot of transiency in our patient population. So having that hub and spoke approach is highly beneficial. It's made a tremendous impact. The other best practice program is the Screening and Brief Intervention and Referral to Treatment program. Again, partnership. We have worked with Blue Cross Blue Shield and the Department of Health, Office of Alcohol and Drug Abuse. And what we've done is we're implementing this screening and brief intervention and referral protocol in both our emergency department and our patient-centered medical home in the clinic. So patients are screened using a best practice tool that's graduated to progress if the patient shows risk, to another screening tool, which then identifies the intensity of the risk, which is followed by either a brief intervention which expresses the concern of the provider about the real health risk of alcohol or drug intake, and a referral to treatment to a provider that can provide that treatment resource. We're, again, because of our partnership with our Dean Mental Health Agency, HCRS, we have an embedded clinician in our clinic 4 days a week. So she is able to, if available, go to the ED the same day, and while the patient is still in the ED, and make that connection with the patient to really start that process. If not, if the referral is after hours or on the weekends, they have a protocol to be able to refer to her, and then she reaches out to the patient, so that it's an active process, which is a change from giving the patient these lists of referral resources and saying, these are your options. We'd encourage you to get some support through these options, and which is much more of a passive process. The other thing to highlight with ESPER is the fact that we've taken this overall health approach. So there's questions that are based in, do you wear seat belts? Do you wear a helmet when you're biking? So it takes some of the sting out of the approach. So people don't feel like they're being put under the spotlight around their alcohol and drug abuse use. And the other piece around ESPER that I'd like to highlight is the real role for motivational interviewing. So that's part of building capacity in the providers to be able to approach the subject in a way that's palatable and makes it easy for a patient to say, yeah, I've been thinking about it, and I know I need help now. I think I'm ready. So again, a best practice approach which is being implemented and we have high hopes for. It's aiming at a population primarily that are not at the high risk range. We're hoping to get people before they get to that point. So that's ESPER. And again, what we did, we tried to maximize the resource of ESPER with some grant support. So we offered motivational interviewing regarding substance use to all our community partners. They were not implementing the whole protocol of ESPER, but at least we were building capacity in our community to be able to talk to, dialogue, and open the door to treatment. And then using our community protocol, okay, one shop stopping, here's the access coordinator. If you have a need, this is the person that we can call, let's call together. Or, you know, this is the person you can call. If you're not quite ready, I'm going to give you this information. So that we're trying to build capacity throughout the community as a system. Again, the population health approach. We have, since the Drug-Free Communities days, developed a strong program using best practices around prevention. And I don't know if you know, but Vermont is, we're in the process. It's going to our governor's desk around the legalization of marijuana, which is a prime concern for us. And so we've spent a lot of time in doing education, provider education and community education around marijuana. Our state as a whole has worked diligently to be able to address the issue using the approach that bringing together the experts from the state and looking at our current practices. So the governor convened a summit for substance misuse workforce and work group, because we know that as this problem and crisis is evolving, we don't have enough of the right people in the right places at the right time with the right credentials and experience to be able to address the extent of the need. So by bringing together professionals throughout the state, we've been able to identify, okay, what are some ways we can streamline our current processes? What are some incentives that we can employ to draw people into the profession? What are some ways that we can maximize the multidisciplinary approach to care? And I again would applaud this effort of the governor. We were invited to be part of that, and we're able to share and express our voice of both what's the extent of the concerns of the workforce, barriers we're experiencing, and come up with some recommendations of how we can overcome those barriers. And that is still, people are still working together to promote implementation of those recommendations and to move forward. One of the things that we recognize at Mount Ascutney Hospital is that, you know, there's dealing with addiction, and there's also dealing with chronic pain. And how do those two overlap or evolve in a patient's life? We all know people that have become addicted, you know, from legitimate prescriptions for injuries and so on, and we have to, you know, that's accentuated the problem that we're now dealing with. It's tough for an individual provider to look in the eyes of a long-term chronic pain patient and say, you know, I've got concerns about your dosage, about what you're taking, and we need to explore alternatives. There's fear. People immediately shut down. It's a tough position to be in. So what we did to overcome that was we formed a multidisciplinary functional recovery consult team for our chronic pain patients. And you'll see the members around the table. What we did, we brought in the medical director, our physiatrist and a physical therapist, psychiatrist, recreational therapy. I sit as the convener and facilitator of the group. Someone from addiction medicine and one of our spoke nurses, as well as an acupuncturist, a massage therapist, a counselor who's skilled in CBT and DBT, and someone from our pain service. And we meet much as a cancer a team would meet. We meet on a monthly basis to be able to receive consults from our physicians so that they've got a safe place to come and talk about, do a patient presentation and talk about the challenges and what the alternatives are. We found that that's immensely helpful, along with, and I have to give credit to our medical director of our clinic, you know, in Vermont we've adopted best practice guidelines for prescribing, for opioid prescribing. And there's been some real transformative protocols put into place because of that. She did a study of the patients that we have on opioids and the dosage and met with individual prescribers. And we talked about strategies and our goal of reducing risk and use. And so this is a natural companion to that approach that she used and is a resource to our providers. We have, again, through the Blueprint for Health, been given funding to create a community health team. These are nurses and social workers who work in conjunction with the spokes, with community agencies to do care management and care coordination. And because we're a small community and we need to work together, we meet, the community health team meets with the spoke practices so that those patients that are in specialty practices are really linked to the patient-centered medical home. I think you know from your own experience that many of the people that we serve and work with don't have a medical home. They're frequently outside the system. So that's one of the goals that that we have adopted, is really working to link patients to primary care and to a holistic system that addresses the patient's needs. I talked before about the prevention work that we've done. One of the things that we started early in our work is developing drop boxes in the community. And these are, ours in Windsor is located at the police station. Anybody in the community can come to drop off meds, you know, when their prescription is you know, when they stop taking a medication. So that they're, you know, our goal in education is, and you'll see the second bullet, the most dangerous leftovers, is those meds that are in people's medicine cabinets or on their kitchen tables or, you know, on their bedroom tables. You know, in fact, I heard a story. When we go out educating, one of the elderly people in the group was bragging to her bridge group about how wonderful this drug OxyContin was. You know, oh my gosh, it's made such a difference in her life. And you know, people you know, are just not thinking about the fact that and we look at our results from our youth risk behavior survey, that this is a prime resource for young people to get access to medications through their grandparents or their families' medicine chests or kitchen tables or bedroom tables. That's one of the major sources of access to meds. So we've done a lot with education and with outreach and media, social media around safety of storage and disposal of medications. Again, be aware, don't share. The other thing we did before the drop boxes and still continues twice a year is drug take back, where the sheriffs have, it's very similar to when you have toxic materials take back in your communities where you can drop it off at the fire station and so on. Well, the sheriffs will take any and all medications, and then they are under, with law enforcement, are packaged and sent for incineration in a very coordinated way, both locally and throughout the state. Obviously, education, outreach in an engaging way that will really bring home the issues to both students and families around prom and grad season is important. If we have people are told about, this party's going to happen on the weekend, we have a relationship with the police where they will go and talk to the parents about what the possible penalties are for serving minors. We've had to combat the whole thought that it's better to have people use at home than be out on the streets driving. And, we're trying to stop that, that it's better not to host, period. And these are the consequences to that. We try to celebrate when people are doing a good job, so we have a retailer compliance recognition program so that people that aren't selling to minors and have great scores, when the compliance checks are done, we'll publicly highlight them and congratulate them, and we take their picture and do a write-up in the papers. And then one of our partners that, over the last, I'd say, 5 to 6 years that we haven't been working with prior to that are our regional planning commissions and our town government to really work together towards developing health in all policies and writing a community policy guide that gives guidance to the communities and really takes into effect what are best practices around drug and alcohol use. Can we and work together to establish tobacco-free and alcohol-free public and town areas? Can we work with issues around density of retail stores and density of paraphernalia, and even the existence of paraphernalia stores that are close to schools, etc. So we've worked in all these different areas in a whole effort to address issues related to prevention. Want to get to this, educate people, and prevent it instead of dealing with the aftermath. I talked about the incineration. That's the drug take back initiative, and the Dropbox. I've gotten ahead of myself, I guess. And the other thing that we've done is we've promoted, if you're working on being a best practice for retailers to decrease access and advertise adult-only products at point of sale, we've worked with them to be, again, recognized. We talked about the education around drinking and marijuana and treatment, drug treatment. And there's this amazing resource called Parent Up that we've been promoting and that we're a partner with, that people can have access to real help and guidelines around how to talk to your children about alcohol and drug use, and how to bond and build relationships, and empowering parents to recognize, well, by golly, you actually do make a difference, and whether you know it or not, your kids listen to you. And so really helping people address those myths that are out there because of parent isolation and fear in an organized way. And we've done, again, a lot of community and group presentations and outreach to this effect. We have that regional prevention partnership with our Mount Ascutney Prevention Partnership, working with a health impact assessment that addresses the issue of alcohol and substance use, and after doing that impact study, disseminated the outcomes so that towns have that accessible to them. One of the, just a little story, one of the towns in our area, Wethersfield, had a drug paraphernalia store called the Magic Mushroom. Again, we mobilized the kids. This store was actually within less than a mile to the school also. So it was particularly offensive. And it was established before the town was aware that there could be zoning actions that could be taken that prohibit the proximity of such stores in proximity to schools. So we actually made it pretty hot and uncomfortable for the Magic Mushroom to operate by public campaigns and meeting and bringing light to the issue. And when they did move, unfortunately to another community, which we feel bad about also, but we shared information with them. When they did move, we worked with the town to adopt the paraphernalia zoning bylaw so that wasn't able to happen again, and we shared that with media outlets. And so, again, our work with partners at Dartmouth Hitchcock Medical Center on marijuana prevention has been important to us. Okay. I did want to talk about outcome measures because with everything we do, I'd say that's the third tenet. Working in partnership is the first one. Second, using best practices. And third is evaluate. So we do have some sources for evaluation. One of those sources comes from the Vermont Prescription Monitoring System. So again, here we get information from the system about our region on a quarterly basis, and we share that with the providers. What you see here is comparing Windsor to the state around rates of prescription for 100 residents. Now, this is one where we're the lowest in the state right now. We have the lowest number of prescription per 100 residents. We're very proud of that, and that didn't come without a lot of work. However, we're not doing so well in some of the other parameters. We still have work that we need to do around for the patients that we prescribe to. What's the dosage? What's the morphine milliequivalent of the dosage that we're using? You know, what's the volume of meds that we're giving? So we're still working, but one of our partners is the prescription monitoring system, and they provide us data. We've been able to work because of the changes in Vermont legislation around prescribing practices with both the University of Vermont and the Medical Society to bring expert trainers to work with our physicians and provide education and help us develop those protocols that we adopted internally. And then we have, again, partnership, can't stress it enough. We organized all of our local partners, particularly around youth services, because we really believe we don't have enough services for our youth. We brought together the court system, law enforcement, the schools, law enforcement, excuse me, prevention, early intervention, and treatment professionals to really summit around what's existing and in both treatment and intervention and prevention, and so we can make resource guides. So again, maximize what's available, and then develop an analysis of what the gaps are. So again, identifying these jointly, we can work on them jointly. We're in this for the long haul, and we're in this to work in partnership. So that's something that we just did this past fall, and we're well on our way of developing those resource guides, both for treatment and for prevention and early intervention. And after that, we'll do the gap analysis so that we can say, okay, now get the whole group together again. This is where we are. Let's work together on what we can do to make it better in our community. Other outcome and performance measures, you can't read this, but this shows the rest of the Vermont prescription monitoring details that are quarterly sent to us. And again, I talked about the percentage of the population receiving at least one prescription. It talks about the average day supply, and using morphine milligram equivalents, and then the proportional opioid anesthetic prescriptions with the daily morphine equivalent categories, and looking at the number of prescription in each drug category. So we get this information, we can track it on a quarterly basis, and it's important for us to see how we're doing and then make sure that we can disseminate it to our providers so it can inform practice. We have longitudinally used the Youth Risk Behavior Survey, and because of our heavy investment in prevention, you know, again, I'm going to brag a little bit about it can make a difference. So looking at alcohol use for 8th and 12th graders, going from 35% to 18% for 8th graders, 65% to 46%. I'm not going to use at first when I saw the too few to document, I thought, yahoo! You know, but that's because we didn't have good enough sample size, so I got to tell you that right off the bat. But again, significant improvements over time, and I think anybody that's in this work knows that you can't skip a class. You can't skip a year. I mean, we're invested in for the long haul. And one of the things that we look over time, again, from 2012 when we started the drug take back in Windsor County, we collected 295 pounds of medications, and then in 2016 you know, so it creeped its way up to 936 pounds. So again, getting it off access where people will be affected. So these outcome measures, evaluating the impact is really important, and it's important to do it in a longitudinal way. And then the last, again, I'm sorry you can't read it again, but I'm just going to use this as an example. The state of Vermont, the Vermont Department of Health has gathered information on initiation and engagement in treatment for substance use, and they've broken that down by counties. So we can look at that information from 2009 to 2016. This is true for both initiation, which is this slide, and then engagement, which is this slide. So we can see how effective we are. You know, we've got a long ways to go from identifying the problem to get somebody into treatment. And I think you all know, sitting around in your tables, that it's easier said than done to get people to follow through to treatment, but that's our goal, is to make it easy, accessible, and to use a warm handoff and a nurturing approach that will make it non-judgmental and part of the whole assessment that this is like diabetes. You need to treat it. We give people insulin. Well, we also have treatments for drug and alcohol use, and so adopting that approach. But again, the emphasis of this part is really looking at, you know, you've got to look at what's available in your communities for outcome measures so you can track how you're doing. So I know you've been listening to me spiel for a long time, and I apologize for that. I hope it's been helpful. I'm at your service. If anyone wants to call, send me an email. My email is jill.m.mahhc.org. I probably should have put it on my slides, so I apologize. But I welcome to hear from you, and I'm going to zip it right now in case you have any questions.
Thank you so much, Jill. That was an excellent presentation, and you can